കേൾക്കാവോ? Am I audible?
Yes, ma'am.
Okay. എല്ലാവരും ചെയ്യോ? ഓക്കെ, സ്റ്റാർട്ട് ചെയ്യട്ടെ. ഇതിൽ എ ബാച്ച് സ്റ്റുഡൻസും ഇല്ലേ? എ ബാച്ച് ആൻഡ് സി ബാച്ച് സ്റ്റുഡൻസ് രണ്ട് ഗ്രൂപ്പിലുള്ള ആളുകളും ഇല്ലേ ഇതിൽ സ്റ്റുഡൻസ്? ആരെങ്കിലും ഒന്ന് റെസ്പോണ്ട് ചെയ്യാവോ?
ഉണ്ട് മാം.
ഓക്കെ. My name is Dr. Amrita, postgraduate student, Department of Community Medicine. For your practical exam, you will get 2 sessions, OSP and OST. So today's classes on some OSP and OST topics. So this is very important for your practical exams. So you can write it in your records also. Okay. നിങ്ങളുടെ പ്രാക്ടിക്കൽ എക്സാംസിന് ഓരോ ക്വസ്റ്റ്യൻസ് ഓരോ സിനാരിയോ ആയിട്ടായിരിക്കും തരുന്നുണ്ടാവുക. ആ സിനാരിയോയിൽ യു വിൽ ഗെറ്റ് സം സബ് ക്വസ്റ്റ്യൻസ്. അങ്ങനെയായിരിക്കും ക്വസ്റ്റ്യന്റെ ഫോർമാറ്റ്. അപ്പം ഞാൻ ഇപ്പോൾ പഠിപ്പിക്കാൻ പോകുന്നത് അങ്ങനെ കുറച്ച് സിനാരിയോസ് ആയിരിക്കും. സോ ഫസ്റ്റ് സിനാരിയോ, a 56-year-old male patient came to OPD with complaints of headache for the past 1 day. No history of any chronic illness in the past and no history of any drug intake. On examination, pulse rate is 68 per minute, the blood pressure 150/90 millimeter mercury, general examination within normal limit, system examination within normal limit. How will you manage this case as a PHCMO? Here you can see patient is complaining of headache for the past 1 day. There is no history of any previous illness, and on examination you can see his BP is little bit high than the normal value. So this is a case of hypertension and it is newly detected hypertension. So ഇങ്ങനെ ഒരു കേസ് നിങ്ങൾ PHCയിൽ MO ആയിട്ട് ഇരിക്കുമ്പോൾ നിങ്ങൾ അടുത്തേക്ക് വരികയാണ്. അപ്പോൾ how will you manage this case? നിങ്ങൾക്ക് അറിയാം PHC പ്രൈമറി ലെവൽ ഓഫ് ഹെൽത്ത് സിസ്റ്റം ആണ്, പ്രൈമറി ഹെൽത്ത് സെന്റർ ഒക്കെ പറയുന്നത്. അപ്പം നമുക്കവിടെ പേഷ്യന്റിനെ ട്രീറ്റ് ചെയ്യുന്നതിന് കുറച്ച് ലിമിറ്റേഷൻസ് ഉണ്ട്. എല്ലാ ഡ്രഗ്സും നമുക്ക് PHC ലെവലിൽ കൊടുക്കാൻ പറ്റില്ല. അപ്പം how will you manage this case in a PHC level? First step you have to check the serum creatinine and urine protein level to rule out any renal impairment or any renal diseases related to this high BP. Then you have to tell lifestyle modifications for 3 months. What are lifestyle modifications? You tell, you ask the patient to this patient for hypertension. ആരെങ്കിലും ഒരാൾ പറയാവോ എന്തെല്ലാം ലൈഫ്സ്റ്റൈൽ മോഡിഫിക്കേഷൻസ് പറയും? ആരും പറയുന്നില്ലേ? ഡയറ്ററി ഓക്കെ, സോൾട്ട് റെസ്ട്രിക്ഷൻ, ദെൻ എക്സസൈസ് എക്സെട്ര. ഓക്കെ, ഞാനത് ഇനി പഠിപ്പിക്കും. ഇപ്പം ലൈഫ് സ്റ്റൈൽ മോഡിഫിക്കേഷൻസ് പറയാം ഫോർ 3 months. എന്നിട്ട് എന്ത് ചെയ്യണം? ഡ്രഗ്സ് സ്റ്റാർട്ട് ചെയ്യണോ ഈ ഇനീഷ്യൽ സ്റ്റേജിൽ തന്നെ? There is no need to start any drugs for newly detected high BP. So lifestyle modifications for 3 months and ask the patient to came every month for review in your OPD. If the patient came to you in the next month and you measure his BP and the BP is still high, then what will you do? Then you have to start tab amlodipine 5 mg once daily for him. Tab amlodipine 5 mg once daily along with the lifestyle modifications and again നിങ്ങൾ പറയണം മന്ത്ലി റിവ്യൂ ചെക്കപ്പിന് വരണം, OPD വരണം പറയണം. അപ്പം നെക്സ്റ്റ് മന്ത് വന്നു, വീണ്ടും ഹൈ BP ആണ്, സ്റ്റിൽ BP is high, then what will you do? Then you can add one more drug, tab telmisartan 40 mg once daily along with the tab amlodipine and ask the patient to come OPD every month if the BP is still high at monthly review. Then what will you do? You can intensify the dose of telmisartan to 80 mg along with amlodipine 5 mg and lifestyle modifications. Then if the BP is still high at the next month, then you can intensify the dose of amlodipine to 10 mg along with the telmisartan 80 mg and lifestyle modifications. But if the BP is not controlled after intensifying the dose of both drugs, then you can add one more drug, that is tab chlorthalidone 12.5 mg. It is a diuretic along with the amlodipine 10 mg and telmisartan 80 mg along with the lifestyle modification. If the BP is not controlled after starting the third drug, then you have to confirm that the patient is taking whether he is taking drugs regularly or not. If the patient is taking regular treatment and the BP is still high, then you have to refer the patient to higher center or a specialist. ഇതെല്ലാരും എഴുതുന്നുണ്ടല്ലോ അല്ലേ? റിപ്പീറ്റ് ചെയ്യാം.
സ്ലോയില് പറയോ, എഴുതിയെടുക്കാൻ ടൈം കിട്ടുന്നില്ല.
ഓക്കെ റിപ്പീറ്റ് ചെയ്യാം. First patient, you have to check the serum creatinine and urine protein level to rule out any renal diseases. And then lifestyle modifications for 3 months and review every month. You ask the patient to come to OPD every month. Then if the BP is high at monthly review, first you have to start tab amlodipine. Amlodipine and the drug പഠിച്ചിട്ടില്ലേ ഫാർമക്കോളജി?
കാൽസ്യം ചാനൽ ബ്ലോക്കർ.
ഓക്കെ, കാൽസ്യം ചാനൽ ബ്ലോക്കർ. amlodipine 5 mg once daily start ചെയ്യുക and review monthly. If the BP is still high at monthly review, then add tab telmisartan 40 mg once daily along with the tab amlodipine 5 mg. if the BP is not controlled, then you can intensify the dose of telmisartan to 80 milligram along with the tab amlodipine 5 milligram. എഴുതുന്നുണ്ടല്ലോ അല്ലേ? എഴുതിയോ നേരത്തെ പ്രീവിയസ് സ്ലൈഡ്?
എഴുതി മാം.
Then if the BP is high at monthly review, then you can intensify the dose of amlodipine to 10 milligram along with the telmisartan 80 milligram. Then if the BP is not controlled, then you can add one more drug. It's a diuretic, tab chlorthalidone 12.5 milligram along with the amlodipine 10 milligram and telmisartan 80 milligram. If the BP is still high, then you have to confirm the compliance to treatment. Then if the patient is still taking drugs regularly but the BP is not controlled, then you have to refer the patient to any specialist or higher center. Okay. എഴുതിയോ? Can I change the slide?
Ma'am, just 1 minute.
Okay. Okay. Then ഞാൻ നേരത്തെ പറഞ്ഞ സിനാരിയോയിൽ BP 150/90. So if the patient came to you for the first time and you check his BP and his systolic BP is more than or equal to 180 or diastolic BP more than or equal to 110 for the first time. So in this case, ഇപ്പം ഈ ഒരു കേസിൽ നിങ്ങൾ ലൈഫ് സ്റ്റൈൽ മോഡിഫിക്കേഷൻസ് പറഞ്ഞ് പേഷ്യന്റിനെ വിടരുത്. ഇത് ഹൈ BP ആണ്. സോ ഇപ്പൊ ഫസ്റ്റ് ടൈം തന്നെ ഇത്രയും ഹൈ BP കാണിക്കുകയാണെങ്കിൽ you have to refer the patient immediately to higher center after starting the treatment. Okay. മനസ്സിലായോ? Then if the systolic BP is 160 to 179 or diastolic BP more than or equal to 100 to 109, then do basic investigations like ECG, serum creatinine, and start on lifestyle modifications and also start the drug treatment. Okay. Then if systolic BP is more than between 140 to 159 and diastolic BP is between 90 to 99, ഈ കാറ്റഗറിയിലാണ് ഞാൻ പറഞ്ഞ സിനാരിയോയിലെ പേഷ്യൻ്റ് ഉള്ളത്. സോ ഇൻ ദിസ് കേസ് you can start on lifestyle modifications for 3 months and later start the drug treatment. എഴുതിയോ?
ഇല്ല മാം.
Can I change the slide? Okay. Then classification of hypertension. This is given in your textbook. Normal BP is less than 130 mmHg systolic BP and diastolic BP is less than 85 mmHg. Then high normal is 130 to 139 millimeter of mercury systolic BP and diastolic BP is 85 to 89 millimeter of mercury. Then grade 1 hypertension. Here the systolic BP is between 140 to 159 and diastolic BP is between 90 to 99. Then grade 2 hypertension, systolic BP is more than or equal to 160 millimeter of mercury and diastolic BP is more than or equal to 100 millimeter of mercury. ഇത് പാർക്കിലുണ്ട്. നിങ്ങൾക്ക് പാർക്കിൽ നോക്കി കഴിഞ്ഞാൽ കാണാം. സ്ലൈഡ് ചേഞ്ച് ചെയ്യട്ടെ. What are lifestyle modifications you tell the patient in case of hypertension? First is change diet, salt restriction, that is less than 5 grams per day. Salt restriction less than 5 grams per day. Then ask the patient to take low fat diet. Then he has to reduce his weight, and the target BMI is between 18.5 to 22.9 kilogram per meter square, and regular exercise is must at this moderate intensity, 30 minutes exercise at least 5 days per week. Then alcohol and smoking, avoid unhealthy intake of alcohol and should stop smoking. Okay, these are lifestyle modifications you have to advise the patient in case of hypertension. എഴുതിയോ? Then in case of hypertension, all adults over 18 years, അതായത് 18 വയസ്സിന് മുകളിലുള്ള എല്ലാവരും സ്ക്രീൻ ചെയ്യണം എന്നാണ് പറയുന്നത്. Okay. Then second scenario, a 60-year-old female patient came to OPD with complaints of fatigue, polyuria, polydipsia, and polyphagia. On routine investigation, her RBS random blood sugar value is 240 milligram per deciliter. How will you manage this patient as a MOPH? What is polyuria? ആരെങ്കിലും പറയാമോ? What is polyuria?
Increased volume of urine.
Excessive urination. Then polydipsia is
Increased thirst.
intake of food. Here you can see patient is these symptoms of the disease plus common items: polyuria, polydipsia, and polyphagia.
Diabetes.
Diabetes. And here her RBS value is 240. It is little bit high. So how will you manage this patient? So this is the diagnostic criteria for diabetes mellitus. This is also given in a PARC textbook. Diabetes is when the fasting plasma sugar value is more than or equal to 126, or postprandial plasma glucose value is more than 200 milligram per deciliter. The next one is impaired glucose tolerance. That is fasting plasma glucose is less than 126 milligram per deciliter, and postprandial plasma glucose level is between 140 to 200 milligram per deciliter. Next is third one is impaired fasting glucose. Fasting plasma glucose values between 110 to 136 milligram per deciliter, and postprandial plasma glucose value less than 140 milligram per deciliter. What is postprandial plasma glucose value? ആർക്കെങ്കിലും അറിയാവോ? ഭക്ഷണം കഴിച്ച് 2 hours കഴിഞ്ഞിട്ട് നമ്മൾ ബ്ലഡ് ഗ്ലൂക്കോസ് വാല്യൂ ചെക്ക് ചെയ്യുക. അതാണ് postprandial plasma glucose. Fasting plasma sugar value is empty stomach ഭക്ഷണം കഴിക്കുന്നതിന് മുന്നേ ബ്ലഡ് ടെസ്റ്റ് ചെയ്യുന്നതാണ് ഫാസ്റ്റിംഗ് പ്ലാസ്മ ഷുഗർ. So here in this case random blood sugar value is more than 200. So how will you manage this case? Lifestyle modifications പറഞ്ഞു വിടുമോ അല്ലെങ്കിൽ ഡ്രഗ്സ് സ്റ്റാർട്ട് ചെയ്യോ? എന്താ ചെയ്യാം? ഡയബറ്റിസ്. Okay, for diabetes, first you have to advise the patient regarding lifestyle modifications and how to assess complications of diabetes, self-assessment of complication of diabetes പറഞ്ഞു കൊടുക്കണം. Then start glucose lowering drugs like first you can start tab metformin 500 milligram once daily or twice daily or BD. Then advise the patient, ask the patient to monitor his FDG or CPBG value monthly. Then hypertension പറഞ്ഞ പോലെ തന്നെ എല്ലാ ഓരോ മന്തും റിവ്യൂവിന് വരാൻ പറയണം. If the FDG and CPBG values are high in the monthly review, then what will you do? Okay, you can intensify the dose of tab metformin to 100 milligram or 1 gram twice daily. Then along with lifestyle modification, then review in next month shows high FDG and PPDG values. Then what will you do? എന്ത് ചെയ്യുമ്പോൾ ഒരു ഡ്രഗിന്റെ ഡോസ് കൂട്ടി ഇനി എന്ത് ചെയ്യാൻ പറ്റും? മരുന്ന് മാറ്റല്ല. You can add one more drug, that is tab-glimepiride 1 milligram once daily. Okay. What is the most common side effect of glucose lowering drugs? Common ആയിട്ടുള്ള സൈഡ് എഫക്ട് എന്താ?
Hypoglycemia.
Very good, hypoglycemia. So when you add tab-glimepiride, you 30 minutes before breakfast. അതായത് tab-glimepiride എടുക്കേണ്ടത് 30 minutes before breakfast. And if നമ്മൾ glimepiride ആഡ് ചെയ്യുമ്പോൾ ഹൈപ്പോഗ്ലൈസീമിയയുടെ സിംറ്റംസും സൈൻസും എല്ലാം പേഷ്യന്റിന് പറഞ്ഞു കൊടുക്കണം. അപ്പൊ if there is the ഹലോ കേൾക്കുന്നില്ലേ? ഹലോ
മാം
അപ്പം he is having any hypoglycemic episode, then you tell that നമുക്ക് അതിന്റെ ഡോസ് glimepiride ഡോസ് 0.5 milligram per day ആയിട്ട് റെഡ്യൂസ് ചെയ്യാം. ഓക്കെ, അപ്പം ആ tab glimepiride 1 milligram OD along with the lifestyle modifications and tab metformin 1 milligram BD and hypoglycemia training. Then നമുക്ക് ഇപ്പം മന്ത്ലി റിവ്യൂ ചെയ്യുമ്പോൾ FDG and PPDG വാല്യൂസ് ഹൈ ആണ് അല്ലെങ്കിൽ വാല്യൂസ് ചേഞ്ച് ചെയ്യുന്നതനുസരിച്ച് നമുക്ക് glimepiride ഡോസ് 1 milligram to 2 milligram വരെ നമുക്ക് ഇന്റൻസിഫൈ ചെയ്യാൻ പറ്റും. ഇപ്പം glimepiride വാല്യൂ 2 milligram വരെ ഇന്റൻസിഫൈ ചെയ്തു. glimepiride ഡോസ് 2 milligram വരെ ഇന്റൻസിഫൈ ചെയ്തു. But if plasma glucose value is level is not under control after second drug, and if any complications or if any symptoms or signs of complications are present, then you have to refer the patient to higher center. Okay, plasma glucose value is not under control and signs and symptoms of complications are present, then you have to refer the patient to higher center or to a specialist. Okay, then if there is no complications present, continue lifestyle modification, metformin 1 gram BD and glimepiride 2 milligram BD. And but if the plasma glucose level is still high but there is no signs or symptoms or complications, then you can add one more drug, that is tab pioglitazone 7.5 milligram once daily And you can also intensify the dose of pioglitazone up to 15 milligram once daily, depending upon the glucose level. Okay. And should avoid pioglitazone in cardiac failure and fluid overload patients. Okay. Then after after the addition of pioglitazone, the plasma glucose level is still high. Then you can start insulin at the PHC level. If the plasma glucose is not under control after starting insulin, then you have to refer the patient to higher center. Okay, അപ്പം ഇൻസുലിനും പയോഗ്ലിറ്റസോണും എല്ലാം ആഡ് ചെയ്യുന്നതിന് മുന്നേ you have to make sure that there is no signs or symptoms of complications. കോംപ്ലിക്കേഷൻസ് ഒന്നും ഇല്ലാതെ ഉറപ്പുവരുത്തിയതിനു ശേഷം മാത്രമേ ബയോഗ്ലിറ്റസോണും ഇൻസുലിനും ആഡ് ചെയ്യാൻ പറ്റുള്ളൂ. എപ്പോഴാണ് കോംപ്ലിക്കേഷൻസ് ഉണ്ടാകുന്നത് അപ്പൊ തന്നെ പേഷ്യന്റിനെ റെഫർ ചെയ്യാം. ഓക്കെ, എഴുതിയോ എല്ലാവരും? ഹലോ, am I audible?
മാം സ്റ്റെപ്പ് 3 ഒന്നുകൂടെ കാണിക്കാം.
Okay, slide change ചെയ്യട്ടെ. ഓക്കെ, നേരത്തെ പറഞ്ഞല്ലോ, hypoglycemia is the most common side effect of glucose lowering drugs. What are the symptoms of hypoglycemia? എന്താ നിങ്ങൾ പേഷ്യന്റിന് അഡ്വൈസ് ചെയ്യാം? ഹൈപ്പോഗ്ലൈസീമിയ വരും എന്നാണ് പറയുന്നത്. എന്തൊക്കെ സിംറ്റംസ് വരാം ഹൈപ്പോഗ്ലൈസീമിയ വരുമ്പോ? ആർക്കും അറിയില്ലേ? cold sweat, trembling of hands, hunger, palpitation, confusion, etc. ഇതൊക്കെയാണ് സിംറ്റംസ് ഓഫ് ഹൈപ്പോഗ്ലൈസീമിയ. പേഷ്യന്റിന്റെ അടുത്ത് പറയണം, നന്നായിട്ട് വയർക്കുന്നു, ഭയങ്കര ക്ഷീണം ഒക്കെ തോന്നുകയാണെങ്കിൽ അവരുടെ അടുത്ത് ഗ്ലൂക്കോസ് നോക്കുന്ന GRBS നോക്കുന്ന ഇതുണ്ടെങ്കിൽ GRBS മെഷർ ചെയ്യാം. എന്നിട്ട് എങ്ങനെ മാനേജ് ചെയ്യാം ഹൈപ്പോഗ്ലൈസീമിയ അറ്റ് ഹോം. You have to advise the patient regarding the management, that is ingestion of glucose or carbohydrate containing food. Consume at least 15 grams of glucose, that is 1 teaspoon of sugar, fruits next meal, and recheck blood glucose after 15 minutes and repeat if the hypoglycemia continues. The പേഷ്യന്റിന്റെ അടുത്ത് നിങ്ങൾ അഡ്വൈസ് ചെയ്യണം, ഇനി ഹൈപ്പോഗ്ലൈസീമിയ സിംറ്റംസ് വരികയാണെങ്കിൽ ഒരു 15, അതായത് ടേബിൾ സ്പൂൺ ഷുഗർ എടുക്കുക, ഫ്രൂട്ട്സ് എടുക്കുക. എന്നിട്ട് പേഷ്യന്റിനും സിംറ്റംസ് വേഴ്സൺ ചെയ്യുകയാണെങ്കിൽ ഹോസ്പിറ്റലിലേക്ക് പോകാൻ പറയാം. ഓക്കെ, എഴുതിയോ? Then lifestyle modifications in diabetes, first restrict sugar and sweet, then restrict fried and oily food, increase fiber in diet, that is green leafy vegetables, all grains, apple, banana, etc. Then regular consumption of seasonal vegetables, brisk walking for 30 minutes daily, 5 minutes warm up, 5 minutes cool down, and avoid tobacco and alcohol. This is a lifestyle modification. Restrict sugar and meals, restrict fried and oily foods, increase fiber in diet, regular consumption of seasonal vegetables, and exercise, that is brisk walking for 30 minutes, 5 minutes warm up, 5 minutes cool down, then avoid tobacco and alcohol. then if any of the following complications are present, refer to higher center. എന്തെല്ലാം കോംപ്ലിക്കേഷൻസ് ഉണ്ട് ഡയബറ്റസിന്? നിങ്ങൾ പഠിച്ചിട്ടുണ്ടല്ലോ മൈക്രോവാസ്കുലർ മാക്രോവാസ്കുലർ അങ്ങനെയൊക്കെ. അപ്പം പേഷ്യൻറ്റിൻ്റെ നമ്മൾ എപ്പോഴാണ് പേഷ്യൻറ്റിനെ റെഫർ ചെയ്യേണ്ടത്? അതായത് അൺകൺട്രോൾഡ് പ്ലാസ്മ ഗ്ലൂക്കോസ് ലെവൽ വിത്ത് സിംറ്റംസ് ഉണ്ടെങ്കിൽ പേഷ്യൻറ്റിനെ റെഫർ ചെയ്യണം. വിഷ്വൽ സിംറ്റംസ് ഉണ്ടെങ്കിൽ റെഫർ ചെയ്യണം. ഫുഡ് അൾസർ, എനി സൈൻസ് ഓഫ് സിംറ്റംസ് ഫുഡ് അൾസർ പ്രസന്റ്, യു ഹാവ് ടു റെഫർ ദ പേഷ്യൻറ്റ് ഹയർ സെന്റർ. നെഫ്രോപ്പതി, അതായത് സ്റ്റോപ്പിംഗ് ഓഫ് യൂറിൻ ഒക്കെ പറയുകയാണെങ്കിൽ റെഫർ ചെയ്യാം. ദെൻ പെയിൻഫുൾ ന്യൂറോപ്പതി, ഇൻഫെക്ഷൻസ് ഓഫ് സെപ്സിസ് ഒക്കെ വരികയാണെങ്കിൽ പേഷ്യൻറ്റിനെ റെഫർ ചെയ്യാം ഹയർ സെന്റർ. ദെൻ ഹൈപ്പർ ടെൻഷനിൽ പറഞ്ഞ പോലെ തന്നെ ഹൈപ്പർ ടെൻഷൻ്റെ സ്ക്രീനിങ് എല്ലാ ഓൾ അഡൽട്ട് ഓർ ഇൻഡിവിജ്വൽ മോർ ദാൻ 18 years ഉള്ളവരെല്ലാവരും ഹൈപ്പർ ടെൻഷൻ സ്ക്രീനിങ് ചെയ്യണം. ഡയബറ്റീസിനാണെങ്കിൽ സ്ക്രീൻ ഓൾ ഇൻഡിവിജ്വൽ അബോവ് 30 years. എഴുതിയോ?
മാം പ്രീവിയസ് സ്ലൈഡ് ഒന്ന് കാണിക്കാവോ?
ഇതാണോ അതോ നെക്സ്റ്റ് പ്രീവിയസ് സ്ലൈഡിന്? Okay. Scenario 3. A 25-year-old female patient with history of irregular menstruation came to OPD. Her height and weight are measured, and height is 155 centimeter and weight is 54 kilogram. Calculate her BMI and comment on it. How will you calculate BMI? എങ്ങനെ ഇക്വേഷൻ എന്താ BMI? BMI എങ്ങനെ കാൽക്കുലേറ്റ് ചെയ്യും?
Weight by height square.
Height in meter.
Okay. Weight divided by height in meter square. എല്ലാവരും BMI കാൽക്കുലേറ്റ് ചെയ്യുന്നത് എനിക്ക് പറഞ്ഞു ആൻസർ കിട്ടിയത്.
26.63.
Very good. Their weight is 54 kilogram, height is 155 centimeter, BMI. അപ്പം ഇത് ഈ പേഷ്യൻ്റ് എങ്ങനെ ഓവർ വെയിറ്റ് ആണോ അതോ ഒബീസ് ആണോ എങ്ങനെ കമന്റ് ചെയ്യും നമ്മൾ BMI വെച്ചിട്ട്? This is the classification according to BMI. Less than 18.5 is underweight, 18.5 to 22.9 normal weight, 23 to 24.9 overweight, more than or equal to 25 obese. ഓക്കെ, അപ്പം ഈ പേഷ്യൻ്റ് ഏത് ലെവലിൽ വരും? വിച്ച് കാറ്റഗറി, ഏത് കാറ്റഗറിയിൽ വരും?
ഒബീസ്.
ഒബീസ് ആണ്. അപ്പം നിങ്ങൾ അഡ്വൈസ് ചെയ്യണം ഹൗ ടു റെഡ്യൂസ് വെയിറ്റ് ആൻഡ് വാട്ട് ആർ ദ കോംപ്ലിക്കേഷൻസ്. ഒബീസ് ആയതുകൊണ്ട് ഇങ്ങനെ ഫ്യൂച്ചറിൽ എന്തെല്ലാം കോംപ്ലിക്കേഷൻസ് വരാം, എങ്ങനെ വെയിറ്റ് കുറയ്ക്കാന്നൊക്കെ അഡ്വൈസ് ചെയ്യാം. ഓക്കെ, എഴുതിയോ? DEC for mass drug administration. നെക്സ്റ്റ് ടോപ്പിക് ആണ് DEC for mass drug administration. DEC എന്താ? DEC കേട്ടിട്ടുണ്ടോ? മാസ് ഡ്രഗ് അഡ്മിനിസ്ട്രേഷൻ എന്താ? കേട്ടിട്ടില്ലേ? നിങ്ങൾ കഴിച്ചിട്ടില്ലേ മരുന്നൊന്നും?
Diethyl carbamazepine.
അതെ, മാസ് ഡ്രഗ് അഡ്മിനിസ്ട്രേഷൻ ഇത് ഏത് അസുഖത്തിനാണ് കൊടുക്കുക? ഏത് ഡിസീസിനാണ് മാസ് ഡ്രഗ് അഡ്മിനിസ്ട്രേഷൻ ചെയ്യുന്നത്?
Deworming.
Deworming. മാസ്റ്റർ ഗ്രേഡ് നമ്മൾ കൊടുക്കുന്നുണ്ടോ? മാസ്റ്റർ ആയിട്ട്
ഫൈലേറിയാസിസ്.
ഫൈലേറിയാസിസ്. DC ഫോർ മാസ്റ്റർ അഡ്മിനിസ്ട്രേഷൻ. Master administration is a principal strategy of the lymphatic filariasis elimination program, and it aims to interrupt the transmission of lymphatic filariasis. Okay. And master administration is administration of single dose of antifilarial drugs to the entire community yearly once for 5 to 6 years. നമ്മൾ 2004 മാസ്റ്റർ അഡ്മിനിസ്ട്രേഷൻ ലോഞ്ച് ചെയ്തത്. ആ സമയത്ത് നമ്മൾ 5 to 6 years അത് ചെയ്യാമെന്നാണ് തീരുമാനിച്ചിരുന്നത്. പക്ഷെ ഇവിടെ കുറെ സ്ഥലത്ത് എൻഡമിക് ആണ് ഫൈലേറിയാസിസ്. അപ്പം നമുക്ക് കേരളത്തിലാണെങ്കിൽ തന്നെ 10 years വരെ ഇത് കണ്ടിന്യൂ ചെയ്ത് പോയിട്ടുണ്ട്. ഏതൊക്കെ ഡ്രഗ്സാ കൊടുക്കുന്നത് മാസ്റ്റർ അഡ്മിനിസ്ട്രേഷന്? DC diethyl carbamazepine. Along with that, diethyl carbamazepine and albendazole. രണ്ട് ഡ്രഗ്സ് ആണ് നമ്മൾ കൊടുക്കുന്നത് മാസ്റ്റർ അഡ്മിനിസ്ട്രേഷൻ. ആക്ഷൻ എന്താണ് ഡൈതൽ കാർബമസെപ്പിൻ ആൻഡ് ആൽബൻഡസോൾ? എങ്ങനെ പ്രിവെന്റ് ചെയ്യും ട്രാൻസ്മിഷൻ ഓഫ് ലിംഫാറ്റിക് ഫൈലേറിയ? DC kills microfilaria and albendazole clears the intestinal worms. Okay. Who should take the drug? എല്ലാരും എടുക്കണോ? എന്തെങ്കിലും എക്സെപ്ഷൻസ് ഉണ്ടോ? Okay. Everybody in the community except pregnant women, children less than 2 years, and persons who are very sick from other illness. And master administration ചെയ്യുന്നത് once in a year on the identified day. ഒരു ദിവസം ആണ് എല്ലാവർക്കും ഒരേ സമയത്ത് സിംഗിൾ ഡോസ് ഓഫ് ഡ്രഗ്സ് കൊടുക്കുന്നതാണ് മാസ്റ്റർ അഡ്മിനിസ്ട്രേഷൻ. ദിസ് ഇസ് ദ ഡോസ് ആൻഡ് നമ്പർ ഓഫ് ടാബ്ലറ്റ്സ്. ഇങ്ങനെയാണ് കൊടുക്കുന്നത്. അതായത് ഇയർ വൈസ് ഒരു ഇയേഴ്സ് വെച്ചിട്ട് എത്ര ഡോസ് കൊടുക്കണം. അതായത് ലെസ് ദാൻ 2 years ഇറ്റ് ഇസ് കോൺട്രാ ഇൻഡിക്കേറ്റഡ്. 2 to 5 years DC 100 milligram ഡോസ് കൊടുക്കണം. അതായത് 1 ടാബ്ലറ്റ്. ഒരു ടാബ്ലറ്റ് 100 milligram. അത് 2 to 5 years ഒരു ടാബ്ലറ്റ് DC ആൻഡ് ആൽബൻഡസോൾ 400 milligram 1 ടാബ്ലറ്റ്. 6 to 14 years 200 milligram DC കൊടുക്കണം. So 2 tablets and albendazole 400 milligram 1 tablet. 15 and above 300 milligram ആണ് dose for DC. That is 3 tablets and albendazole 400 milligram 1 tablet. Okay. Then some important insecticides. ഇത് നമുക്ക് സ്പോട്ടർ ആയിട്ട് വെക്കാൻ സാധ്യതയുണ്ട്. അപ്പം നിങ്ങളുടെ പാർക്കിൽ ഒരുപാട് ഇൻസെക്ടിസൈഡ്സ് പറയുന്നുണ്ട്. പക്ഷെ ഇത് ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ളത് ഇത്രയാണ്. അപ്പം ഫസ്റ്റ് വൺ ഇസ് മാലാത്തയോൺ. നിങ്ങൾക്ക് കേട്ടിട്ടുണ്ടോ മാലാത്തയോൺ എന്താണ്? എൻഡമോളജി ക്ലാസ് കഴിഞ്ഞിട്ടില്ല അല്ലേ? ഇതിന്റെ ഫോഗിങ് എന്താ? ഫോഗിങ് ഇൻഡോർ റെസിഡ്യൂൽ സ്പ്രേ, ഇൻഡോർ സ്റ്റേ സ്പ്രേ എന്നൊക്കെ കേട്ടിട്ടുണ്ടോ? ആരെങ്കിലും ഒന്ന് റെസ്പോണ്ട് ചെയ്യാവോ? ഫോഗിങ് എന്ന് പറയുമ്പോൾ നമ്മൾ ഔട്ട്സൈഡ് ദ ഹൗസ്, നമ്മൾ പുറത്ത് ഇങ്ങനെ പുകയ്ക്കുന്നത് കണ്ടിട്ടില്ല, അതാണ് ഫോഗിങ് എന്ന് പറയുന്നത്. ഇപ്പൊ മാലാത്തയോൺ അഡൽട്ട് മോസ്കിറ്റോസ്, അതായത് ഫോഗിങ്ങിന് ഉപയോഗിക്കുന്നത് ഏജന്റ് മാലാത്തയോൺ ആണ്. ഡോസസ് 100 to 200 milligram per square feet. ഫോഗിങ് നമ്മൾ കോമൺ ആയിട്ട് ചെയ്യുന്നത് ഡെങ്കു കേസസ് ഡിറ്റക്ട് ചെയ്യുമ്പോൾ, ഡെങ്കു കേസസ് വരുമ്പോഴാണ് ഫോഗിങ് ചെയ്യുന്നത്. നെക്സ്റ്റ് അബേറ്റ് ഓർ ടെനിഫോസ് പ്രോസസ് 20 ml per meter square of water containers അത് നമ്മൾ വൺസ് വീക്ക്ലി ചെയ്യണം. ഇറ്റ് ഇസ് എ ലാർവിസൈഡ്. മലാത്തയോ അഡൽട്ട് മോസ്കിറ്റോസിനെയാണ് നശിപ്പിക്കുന്നത്. അവൈറ്റ് ഇസ് എ ലാർവിസൈഡ്. Then pyrethrum extract. In the indoor stage spray and the indoor residual spray. Indoor means inside. അതായത് ഉള്ളിലാണ് ചെയ്യുന്നത്. അതിൽ സ്പേസ് സ്പ്രേ എന്ന് പറയുമ്പോൾ ഇൻ ദ സ്പേസിൽ നമ്മൾ എന്താ പറയുക ഇത് അപ്ലൈ ചെയ്യുന്നതിനാണ് ഇൻഡോർ സ്പേസ് സ്പ്രേ എന്ന് പറയുന്നത്. ഇൻഡോർ റെസിഡ്യൂൽ സ്പ്രേ എന്ന് പറയുമ്പോൾ റൂമിനുള്ളിൽ തന്നെയാണ്. ഈ വാൾസിലൊക്കെ ഉള്ള മൊസ്കിറ്റോസിനൊക്കെ നശിപ്പിക്കാൻ വേണ്ടിയിട്ടാണ് ഇൻഡോർ റെസിഡ്യൂൽ സ്പ്രേ ചെയ്യുന്നത്. കോമൺ ആയിട്ട് ഇൻഡോർ സ്പേസ് സ്പ്രേക്ക് ഉപയോഗിക്കുന്നതാണ് പൈറത്രം എക്സ്ട്രാക്ട്. ആൻഡ് ദ ഡോസ് ഇസ് 2% പൈറത്രം എക്സ്ട്രാക്ട് in 1:19 ratio with kerosene. It is also kills adult mosquitoes. Then pyriscreen. Pyriscreen is used to control anopheline larvae by spraying us 2% dust over breeding places once in a week. Then indoor residual sprays നമ്മൾ ചെയ്യുന്നത് മലേറിയ കേസസ് ഒക്കെ റിപ്പോർട്ട് ചെയ്യുമ്പോഴാണ് ഇൻഡോർ റെസിഡ്യൂൽ സ്പ്രേ ചെയ്യുന്നത്. ലാംഡ സൈലോസ് എന്ന് പറയുന്ന ഇൻസെക്ടിസൈഡ് ആണ് ഇൻഡോർ റെസിഡ്യൂൽ സ്പ്രേക്ക് യൂസ് ചെയ്യുന്നത്. ശരിയോ? Can I change the slide? Epidemiological indices in malaria. നിങ്ങൾ ആനുവൽ ബ്ലഡ് എക്സാമിനേഷൻ റേറ്റ്, ആനുവൽ പാരസൈറ്റ് ഇൻസിഡൻസ്, അങ്ങനത്തെ ഇൻഡെക്സ് ഒക്കെ കേട്ടിട്ടുണ്ടോ മലേറിയ പ്രോഗ്രാംസ് വായിച്ചപ്പോൾ? അപ്പോൾ there are some epidemiological indices in malaria. It is to assess the burden of disease in the community in terms of morbidity, mortality of malaria, and it is to calculate by calculating this indices to monitor and evaluate national health programs of malaria. എത്ര ഇൻഡിസസ് ഉണ്ട്? First one is annual blood examination rate or ABER, just calculated by the formula that is mere examined in a year into 100 divided by total population. Next one is annual parasitic incidence or API, that is total number of positive slides for parasites in a year divided by total population into 1000. Annual blood examination rate is into 100. Annual parasite incidence is into 1000. Then annual falciparum incidence, total positive Plasmodium falciparum sites in a year into 1000 divided by total population. Next one is slide positivity rate. It is total number of positive slides into 100 divided by total slides examined. Next one is slide for falciparum rate. That is total positive Plasmodium falciparum in slides divided into 100 divided by total slides examined. Then Plasmodium falciparum percentage, total positive for Plasmodium falciparum into 100 divided by total positive for malaria parasite.
മാഡം പ്രീവിയസ് സ്ലൈഡ് ഒന്ന് എടുക്കോ? ഓക്കെ താങ്ക് യു മാം.
ഓക്കെ. ഇത് നിങ്ങൾക്ക് സ്പോട്ട് ടെസ്റ്റിൽ ക്വസ്റ്റ്യൻ ആയിട്ട് വെക്കും. അപ്പം ABERും APIയും ഭയങ്കര ഇമ്പോർട്ടൻ്റ് ആണ്. അപ്പം എല്ലാ ഇക്വേഷൻസും പഠിക്കണം, പക്ഷെ ABERും APIയും തെറ്റരുത്, കൺഫ്യൂഷൻ വരരുത് അങ്ങോട്ടും ഇങ്ങോട്ടും. എന്തെങ്കിലും ക്വസ്റ്റ്യൻ വെക്കും സ്പോട്ട് ടെസ്റ്റിന്. ഓക്കെ, ക്വസ്റ്റ്യൻ എഴുതിക്കോ. The population of Chettigar RSTC area is 80,000. The field staff collected 9,000 blood slides in the year 2019. Lab technician examined 8,000 slides. Calculate annual blood examination rate. ADER. Calculate ചെയ്ത് ആൻസർ പറയും. ചെയ്തോ? ആൻസർ എത്ര കിട്ടി? ABR എത്ര കിട്ടി?
1000.
1000 ആണ്. എന്താ ഇക്വേഷൻ എന്താ?
സോറി മാഡം, എനിക്ക് ചെറുതായിട്ടൊന്ന് മാറിപ്പോയി.
10% കിട്ടിയോ അടുത്തെങ്കിലും? ABR is total number of slides examined into 100 divided by population under surveillance. So here total slides examined is 80,000. Population under surveillance is 8,000 slides examined, and population under surveillance is 80,000 into 100. That is 10%. കിട്ടിയോ?
കിട്ടി മാഡം.
Okay. And ABR or annual blood examination rate. അപ്പം നമുക്ക് നിങ്ങൾ ഇക്വേഷനിൽ നോക്കി കാണാം, നമ്പർ ഓഫ് പോസിറ്റീവ് കേസസ് ഒന്നുമല്ല, ടോട്ടൽ നമ്പർ ഓഫ് സ്ലൈഡ്സ് എക്സാമിൻഡ് ആണ് നമ്മൾ നോക്കുന്നത്. അപ്പം ഇറ്റ് ഇസ് ദ ഇൻഡെക്സ് ഓഫ് ഓപ്പറേഷണൽ എഫിക്കസി ഓഫ് ദ മലേറിയ കൺട്രോൾ പ്രോഗ്രാം. അതായത് ABR കൂടുതലാണെങ്കിൽ നമ്മൾ കൂടുതൽ സ്ലൈഡ്സ് എക്സാമിൻ ചെയ്യുന്നുണ്ട്, പ്രോഗ്രാം നന്നായിട്ടാണ് മുന്നോട്ട് പോകുന്നതെന്നാണ് അത് ഡിനോട്ട് ചെയ്യുന്നത്. ഓക്കെ, ABR is the index of operation efficacy of the malaria control program. Then next question. The population of Ambalappuzha UHTC area is 75,000 and the field staff collected 8,000 blood slides in the year 2019. Lab technician examined 6,000 slides, out of which 5 slides were positive for malarial parasite. Calculate annual parasite incidence. Okay, എത്ര കിട്ടി API?
.06.
അതെ, API is the total sites positive for malaria parasite into 1,000 divided by population under surveillance. That is 5/75,000 into 1,000 വരും. 0.06 per 1000 population. അപ്പം നിങ്ങൾ ആൻസർ എഴുതുമ്പോൾ ജസ്റ്റ് 0.6 മാത്രം എഴുതിയാൽ പോരാ. You have to write in this format, that is 0.06 per 1000 population. Okay. പിന്നെ എപ്പോഴും എല്ലാ സ്റ്റെപ്സും വേണം ആൻസർ ചെയ്യുമ്പോൾ. അപ്പം ജസ്റ്റ് നിങ്ങൾക്ക് ഇക്വേഷൻ അറിയെങ്കിലും ഇക്വേഷൻ ജസ്റ്റ് എഴുതി വെക്കണം, എന്നാലേ ഫുൾ മാർക്ക് കിട്ടുള്ളൂ കേട്ടോ. Annual parasite incidence is the measure of malaria incidence in a community. എത്ര കേസസ് പോസിറ്റീവ് ആയതാണ് നമ്മൾ നോക്കുന്നത്, ന്യൂ കേസസ് എത്രയുണ്ട്. ദിസ് എ മെഷർ ഓഫ് മലേറിയ ഇൻസിഡൻസ് ഇൻ എ കമ്മ്യൂണിറ്റി. And areas with ATI more than 2 or more than or equal to 2 per 1000 population per year have been classified as high risk areas in India. Next is vector surveillance for dengue control. നിങ്ങൾ വെക്ടർ സർവേക്ക് പോയില്ലേ? അപ്പോൾ കുറെ ഇൻഡിസസ് ഒക്കെ പറഞ്ഞു തന്നിട്ടുണ്ടായില്ല. ഹൗസ് ഇൻഡെക്സ്, കണ്ടെയ്നർ ഇൻഡെക്സ്, ബ്രിട്ടോ ഇൻഡെക്സ്. അപ്പം these are the most used indicators for vector surveillance. That is house index. House index is the percentage of houses infested with larvae or pupae. Then container index is percentage of water holding containers infested with the larvae or pupae. Then Britto index. Britto index is very important. That is the number of positive containers per 1000 houses inspected. Okay, this is a question. Vector survey team from Punnapura North PHC visited 100 houses in Ward 5. Out of 200 containers, 55 containers showed larval breeding. Calculate Britto index.
$55.
Britto index is number of positive containers divided by total number of houses visited, and number of positive containers into 100 divided by total number of houses visited, that is 55. Okay. എന്തെങ്കിലും ഡൗട്ട്സ് ഉണ്ടോ? Any doubts? എന്തെങ്കിലും സ്ലൈഡ്സ് എഴുതാത്തതോ അങ്ങനെ എന്തെങ്കിലും ഉണ്ടെങ്കിൽ
ഈ സ്ലൈഡ്സ് ഒന്ന് ഷെയർ ചെയ്യോ?
ചെയ്യാം. നിങ്ങൾക്ക് അറ്റൻഡൻസ് ഗൂഗിൾ ഫോം ക്രിയേറ്റ് ചെയ്തിട്ടുണ്ട്. ഞാൻ ആർക്കിഫിലും ശ്രീലക്ഷ്മിക്ക് അയക്കാം. 3 minutes ഓപ്പൺ ആവുള്ളൂ, അതിനുള്ളിൽ അറ്റൻഡൻസ് മാർക്ക് ചെയ്യണം കേട്ടോ.
ഹലോ
Okay, ma'am.
ഹലോ മാം.
ആ
3 minutes ഇവിടെ നെറ്റ്വർക്ക് ഇഷ്യൂസ് ഉള്ള ഒത്തിരി പേരുണ്ട് മാം. 3 minutes ചിലപ്പോൾ ശരിയാവില്ല, കുറച്ചുകൂടെ ടൈം ഇടാവോ?
എത്ര സമയം വേണം? എല്ലാരും വീട്ടിലാണോ?
വീട്ടിലാണ്. ഇപ്പൊ മഴയൊക്കെ ആയതുകൊണ്ട് നെറ്റ്വർക്ക് പ്രശ്നങ്ങളുണ്ട്. ഇപ്പൊ കുറെ പേര് എന്നെ വിളിക്കുന്നുണ്ടായിരുന്നു, അവർക്ക് കേറാൻ പറ്റുന്നില്ല എന്നൊക്കെ പറഞ്ഞിട്ട്.
ആണോ? ഓക്കെ. 10 minutes 5 minutes മതിയാവോ?
ഓക്കെ.
എന്തെങ്കിലും ആർക്കെങ്കിലും പ്രശ്നം പറയുകയാണെങ്കിൽ എന്നെ വിളിക്കും, ഞാൻ എക്സ്റ്റെൻഡ് ചെയ്യാം. ശരി, താങ്ക് യു.
താങ്ക് യു മാം.
Okay.
Good afternoon.
Good afternoon, ma'am.
Good afternoon. Can you hear me?
Yes, ma'am.
Okay. So, shall we start?
Okay, ma'am.
Can you see the presentation?
Yes, ma'am.
Okay. Um, Okay, so today's class is pericardial diseases. It's not peripheral cardiac disease, which was given in your topic list. It is a printing mistake. So it's pericardial diseases. So all of you know that pericardium, it's actually a fibroelastic sac which is made up of a visceral and parietal layer, and it is separated by a potential space called the pericardial cavity. So the parietal layer has a fibrous part as well as a serous part, and the visceral pericardium has got a serous layer, and it is attached to the epicardium. Now, in healthy individuals, normally there is 15 to 50 ml of serous fluid inside this pericardial cavity, and which is an ultrafiltrate of the plasma. And the pericardium is also well innervated. So usually, what are the functions of normally the functions of the pericardium? It limits the motion of the heart. That is, it will not allow the over distension of the cardiac chambers, and undue motion of the heart. So, and also it prevents the dilatation during volume increase. And you know that there are certain conditions in which there is volume overload, such as a certain hyperdynamic circulation, etc. So it will prevent the undue dilatation of the cardiac chambers, and also it acts as an important barrier to infections of the heart. It will prevent the direct infection of the heart. So generally, the pathophysiology of disorders of pericardium, there is an etiology, and following that, there is an inflammatory response. And following an inflammatory response, there is influx of neutrophils and other chemical mediators. There is a change as a result, there is a change in the permeability of the pericardial vascularity. There is pericardial inflammation and edema, as well as accumulation of the fluid in the pericardial cavity or the space. And as the fluid goes on accumulating, there is restriction of the heart motion, and also there is, due to inflammation of the pericardium, you know, it is well innervated. There is pain there is pain. Chest pain is also there, and also there will be associated pain with breathing, because due to the inflammation of the surrounding flora. So diseases of pericardium can be divided, or they are usually present clinically in any one of the following four ways. One, it can present as acute pericarditis, or it can present as a pericardial effusion without major hemodynamic compromises, or it can present as a cardiac tamponade, or as a constrictive pericarditis. So we look for the etiology, which I have mentioned about in the pathophysiology. For pericardial diseases, there are a lot of causes, and the major causes which we see are, one is idiopathic cause. So idiopathic pericarditis can occur, following which an effusion can occur. It can recur and can lead to a chronic pericarditis or chronic constrictive pericarditis, etc. Or due to sudden accumulation of fluid, it can lead to cardiac tamponade. So idiopathic causes are there. Then infections such as viral, bacterial, mycobacterial, fungal, protozoal, which are common. So we will be seeing more about infections causing pericarditis in detail in later slides. The next is neoplasm. Neoplasms, there could be primary neoplasms such as mesothelioma, then fibrosarcoma, lipoma, etc. Then secondary, that is metastatic malignancy, metastatic tumors such as those from breast and lung carcinoma, lymphomas, malignant effusion due to lymphomas can occur, Kaposi sarcomas, which is especially seen in HIV. Then various paraneoplastic syndromes can also cause pericardial effusion, pericarditis. Then next is cardiac causes. Most commonly in early post-myocardial infarction, the patient can develop pericarditis and effusion. Then in a late period of post-myocardial infarction, that is about 3 to 4 weeks post an event, patient can develop effusion, and that is more likely due to an autoimmune condition or a hypersensitivity reaction, not directly due to injury. So in that case, it is called late post myocardial infarction syndrome or the Dressler syndrome. Then after cardiotomy or pericardiotomy, after various procedures related to the heart and pericardium, it can cause pericarditis or pericardial effusion. Then myocarditis can cause associated pericarditis. Then dissecting aortic aneurysm can cause bleeding into the pericardium and can cause cardiac tamponade. Then post-traumatic, secondary to blunt trauma or penetrating trauma, etc. And then various autoimmune diseases can cause pericarditis, rheumatic fever, then various connective tissue diseases such as SLE, rheumatoid arthritis, scleroderma, mixed connective tissue disease, then various arthritis such as polyarthritis nodosa, temporal arthritis or giant cell arthritis, then vaginous granulomatosis, then other diseases such as inflammatory bowel disorders such as ulcerative colitis and Crohn's disease, then Behçet's disease, etc. also can cause pericarditis. Then various drugs causing pericarditis include procainamide, hydrolysine. You know that procainamide, hydrolysine, etc. may also induce lupus. So lupus causing drugs can again lead to pericarditis. Then phenytoin, isoniazid, minoxidil, and anticoagulants. Anticoagulants especially can, if there is a coagulopathy secondary to anticoagulants, it can cause bleeding into the pericardium and cardiac tamponade. Then methotrexate. Methotrexate can cause fibrosis, can cause constrictive pericarditis. Doxorubicin, it is an anti-neoplastic chemotherapy drug, again can affect the pericardium. Phenylbutazone. And other metabolic causes include in hypothyroidism, mixed edema, you will get pericardial effusion. And in uremia, that is when the patient goes for renal failure, there is accumulation, there is an increase in the blood urea, uremia is there, and that again causes a pericarditis and a pericardial effusion. Then another is ovarian hyperstimulation syndrome, and that can cause inflammation of all the serosal cavities such as pericarditis, pleuritis, peritonitis, etc. Then another is cholesterol pericarditis, otherwise it is known as gold paint pericarditis. Then chronic renal failure in patients with chronic renal failure, those who are undergoing maintenance hemodialysis, dialysis related pericarditis can occur. Then chylopericardium, you know that the lymphatic duct in the thorax goes along, related to the heart and the other structures, mediastinal structures. So any rupture of the thoracic duct can cause chylopericardium into the pericardial cavity, can cause a chylopericardium, chylous pericardial effusion. And hyperthyroidism also can cause a pericardial effusion like hypothyroidism. Pericardial effusion is common with hypothyroidism, and amyloidosis also can cause. Then trauma related, I've already mentioned blunt and penetrating trauma can cause. Then iatrogenic, especially during certain cardiac procedures, such as cardiac catheterization, or while we are inserting a pacemaker, that can perforate and perforate the cardiac or the heart walls or the blood vessels, can cause a pericardial tamponade. Then after cardiopulmonary resuscitation also, there is trauma to the secondary to rib fracture or something, there could be trauma to the pericardium and cause pericardial effusion or tamponade. Then post radiation. So after radiation also it can cause thickening of the pericardium and chronic constrictive pericarditis like conditions. Then certain congenital conditions of pericardium include various cysts and congenital absence of pericardium. Then, so regarding infections which cause pericardial disease, viral infections, the most common are echovirus, then Coxsackie virus, then adenovirus, then cytomegalovirus, Epstein-Barr virus, hepatitis B virus, mumps virus, parvovirus B19, HIV and AIDS. So most of these are the common viruses we hear. Then bacterial causes include all the gram-positive bacteria, pneumococcus, staphylococcus, streptococcus, then mycoplasma chlamydia, Lyme's disease caused by Borrelia recurrens, then Haemophilus influenzae, Neisseria meningitidis, that is a meningococcal bacteria, then Legionella, Salmonella, which causes enteric fever, then syphilis, syphilitic pericarditis can occur. Then Mycobacterium, very most important cause in our setting, Mycobacterium tuberculosis is a cause for pericardial effusion. Tuberculous pericarditis is a very common, we can see. Then atypical Mycobacterium can also cause pericarditis. Then fungal infections such as histoplasmosis, coccidioidomycosis, even Candida, aspergillosis can cause pericarditis. Then various protozoa, then parasitic such as echinococcus, amoeba, toxoplasma, etc. can cause pericarditis. So pericarditis, you know, it is the inflammation of the pericardial sac, and we generally divide pericarditis according to the duration into acute, subacute, and chronic. So the most common type we find is acute pericarditis, and the division is as follows based on the duration. If it is less than 6 weeks, it's acute pericarditis. Duration between 6 weeks to 6 months, it's subacute, and more than 6 months, it is chronic. And acute is again subdivided into effusive fibrinous, subacute into effusive constrictive and constrictive, and chronic into constrictive and effusive adhesive. So pathogenesis and pathology of pericarditis. I have mentioned earlier in the slide, there is inflammatory cause which causes vasodilatation, increased vascular permeability, and leukocyte exudation. And pathologically, the pericarditis can be divided into serous, serofibrinous, purulent, and hemorrhagic. So in serous, if we do a pericardial biopsy, we can see there are small cells. In serofibrinous, there is associated scarring also. And in purulent, there is intense inflammation, it's pyogenic. And hemorrhagic, there is presence of red blood cells. So usually seen in TB or secondary to malignancy, or even secondary to trauma. So pericarditis, it's TB and malignancy. Now, clinical features. The most important feature is chest pain. So it is similar to myocardial infarction, but there are certain features which we can clinically differentiate from a chest pain due to myocardial infarction, because pericarditis can also occur secondary to myocardial infarction. So the chest pain will be sudden onset. It will be retrosternal, similar to myocardial infarction. It can radiate to back, especially the interscapular area. It can radiate to the neck, left arm, and left shoulder. Then it is sharp and pleuritic. Unlike myocardial infarction, which is constricting type, this one is sharp and even pleuritic due to inflammation of the surrounding pleura. So it is a sharp type of pain. It's exacerbated on coughing and deep inspiration, and there is a positional variation. It worsens on supine, on lying down or in supine position, and improves when the patient sits up and leans forward. And there will be associated fever based on the etiology, and also patient will be having breathlessness, exertional breathlessness, or breathlessness at rest can occur. So the common DDs of acute pericarditis is myocardial infarction and a pulmonary infarction. So based on the symptoms and signs and relieving and aggravating factors, we can differentiate clinically. So in MI, the pain is retrosternal, whereas in pulmonary infarction, it could be anterior, posterior, lateral, any location, not strictly retrosternal. In pericarditis, it is retrosternal. In MI as well as pericarditis, the pain is, in all the three, the pain is sudden. And then in MI, the character of the pain is, it's a pressure-like heavy squeezing, constricting type of pain. Whereas in pulmonary infarction, it is stabbing, sharp and stabbing. Because in pulmonary infarction, there is pleuritis associated. In pericarditis also, it is sharp and stabbing, but sometimes a patient can develop a dull aching pain. And the chest pain, there is no variation with respiration in case of myocardial infarction. And in pericarditis, it can increase with inspiration due to associated pleural inflammation. And there is no change in position in case of myocardial infarction or pulmonary infarction. Pericarditis, you know, It worsens supine position and decreases with sitting forward position. And there is radiation to jaw, neck, shoulder, and arms in case of myocardial infarction. In pulmonary infarction, there is only radiation to shoulder. In pericarditis, it's similar to myocardial infarction, and also to the trapezius muscle, the pain can radiate. And in myocardial infarction, the duration is minutes to hours. Pulmonary infarction duration could be from hours to days. And also in pericarditis, it can continue from hours to days. And in myocardial infarction, response to nitroglycerin, there is response to nitroglycerin. So the pain is decreased. And in other two conditions, there is no response to nitroglycerin. And on examination, a pericardial rub will be present in case of pericarditis, will be absent in case of other two conditions. And in case of myocardial infarction, when it is associated with dyspnea and orthopnea, dyspnea and features of acute left ventricular failure, there will be on auscultation, you will get a left ventricular third heart sound, that is LVS3, and also features of pulmonary conditions such as bilateral basal crux. Okay, and in pulmonary infarction, the lungs will be, chest will be clear. And in pericarditis also, you will not get any features of pulmonary venous condition. Now, the other feature in pericarditis is chest pain is a major feature. Another clinical sign is pericardial friction rub. The presence of pericardial friction rub, it's present in 85% cases, and it's highly specific, though the sensitivity is variable. So high-pitched, it is a high-pitched, scratchy or squeaky sound. It's best heard with the diaphragm of the stethoscope at the lower left sternal border with the patient leaning forward. So that is the position where you can hear a pericardial friction rub. Usually, it is a systole diastolic sound. That is, you can hear the sound both in the systole as well as the diastole. And usually it has 3 components or sometimes 2 components. So 3 components means it corresponds to, one is in the systole, it corresponds to ventricular contraction. In early diastole, ventricular filling, and atrial contraction in the late diastole. The sounds correspond to. So you will get a systole-diastolic sound, and sometimes the sounds may be intermittent. If you hear the sound, suppose you examine the patient now and you are hearing a pericardial friction rub, after treatment, sometimes it may subside. And sometimes after 2 or 3 days, it may again appear. So it may be intermittent. And it's also during respiration, it is throughout the respiration. There is no variation with respiration. It is audible throughout the respiration. Whereas in case of a pleural rub, it's absent when the patient catches hold of his breath. So when the respiration is held, in pleural rub it disappears, but whereas in case of pericardial friction rub, it is still present. So that is the differentiating point between pleural and pericardial rub clinically. So what are the diagnostic things? So clinical history, of course, helps in diagnosis, and the important investigation is the ECG. So the electrocardiogram, it's almost abnormal in 90% of cases. So the findings you find is a diffuse ST elevation and a PR segment depression. So if you look at this ECG, you can see that the ST segment, that is the end of the QRS and the till the end of the T wave. So it is elevated. It is elevated from the baseline. And also the PR segment, that is the beginning of the P wave to the end of to the beginning of the QRS. That segment is depressed. And in all leads, you will find ST elevation. In all leads, and the shape of the elevated ST is concave, unlike convex shape in myocardial infarction, is more like convex shape or straight. So that is a feature of ECG features you see in early pericarditis, especially in the first week. After the first week and second week, most probably these ST elevations will normalize and no other changes will be there. And in the third week, sometimes you will find only T inversions. Okay, so ST elevation is present in all leads except in the AVR lead. And then in the third week, you will get only T inversions, and sometimes after 4th week, there may be T inversion, persistent T inversion, or it will normalize. So that is the ECG finding. So initially you will get diffuse ST elevation and PR segment depression. Now, next investigation is echocardiography. It's often normal because there is only pericarditis. If there is associated pericardial effusion, you can find the pericardial effusion on echocardiogram, nothing else. So in chest X-ray also, if there is a pericardial effusion, you will get a cardiomegaly. If there is no pericardial effusion, you will not find anything abnormal on chest X-ray. And depends on the etiology also. So there is some other cause. Suppose it is traumatic, like secondary to injury, you can find fracture, etc., like that. Depends on the etiology. Normally, if the chest X-ray is normal. Then cardiac biomarkers, if there is associated myocardial injury, that is post-MI and all, the troponins, cardiac troponins will be increased. Then inflammatory markers, secondary to autoimmune diseases or infections, inflammatory markers such as elevated WBC count, then CRP, ESR, etc. will be elevated, associated. In case of tuberculosis, you can do a Mando test. Mando test might be positive, or you will, if the patient is having sputum, cough and sputum, you can check for the the sputum AFB or CBNAT for Mycobacterium tuberculosis. Then and also to rule out other autoimmune diseases, various autoimmune antibodies such as ANA, anti-dsDNA, or an ANA profile to rule out mixed connective tissue disease, scleroderma, etc. All the autoantibodies related to them can be checked. And also you have to evaluate for malignancy. You know, lung and breast malignancy can cause secondary depositions. So you have to evaluate for that, or even lymphomas can cause malignant effusions. So sometimes the patient will be presenting with pericarditis, chest pain, or pericardial effusion. You will have to rule out malignancies also, common malignancies. So the continuation of the previous slide. So in the previous slide, we had differentiated myocardial infarction, pericarditis, and pulmonary embolism with the chest pain and other findings. Now, on examination, also friction rubbers is present in pericarditis only. Okay, in pulmonary embolism, it is there is pleural friction rub. That is, there is a pleural rub is present in pulmonary embolism because there is associated pleurisy. Then in MI, in ECG, it will be convex ST segment elevation. There is no PR segment depression. Whereas in pericarditis, there is widespread concave ST segment elevation and a PR segment depression. And in pulmonary embolism, most probably we will get a sinus tachycardia only. No ST segment or PR segment variations will not be there. Okay. And in pulmonary embolism, sometimes we get a S wave, a deep S wave in first lead, then T inversion and Q waves in the third lead 3. So that is very rare. Most probably we get a sinus tachycardia in pulmonary embolism. Now treatment. So the treatment is targeted to the underlying etiology. Maximum it is targeted to the underlying etiology. For example, if it's infection, you have to viral or bacterial, or you have to treat the infection also. Then only the pathology will be, you can then only it will resolve. And most of the cases of acute pericarditis can be managed medically. And for the after the treatment of etiology, for the chest pain, aspirin or NSAIDs are given usually for 1 to 2 weeks. And if it is post-MI, in myocardial infarction, we avoid NSAIDs. And dosage of aspirin is high, very high dose of aspirin. We give 650 to 1000 milligram TDS or even Q6 hourly for 1 to 2 weeks. And Brufen, ibuprofen can be given 600 to 800 milligram TDS for again 1 to 2 weeks can be given. So it mainly decreases the chest pain. And then in some cases, when chest pain is not responding to the NSAIDs or aspirin, we can give colchicine. It's in addition to the NSAIDs or aspirin, 0.5 to 0.6 milligram BD into, sometimes it may need 3 months. Even to, it also avoids recurrence of pericarditis. In some idiopathic causes, there may be recurrent pericarditis. Then steroids, use of steroids is restricted. We cannot use in all cases. So steroids is used in, as far as possible, avoid steroids as a first choice. So it is used in refractory cases where the chest pain does not respond to aspirin or colchicine. Then in connective tissue disorders, sometimes we need to use steroids. Then autoimmune, uremic pericarditis, etc., we need to use steroids. And sometimes in TB pericarditis also, sometimes steroids are needed. And in if the etiology, we have found etiology as tuberculosis, tuberculous pericarditis, you have to treat it with anti-tuberculous treatment, ATT. Then if you have found is a purulent pericarditis, you need to drain the fluid and also give IV antibiotics accordingly. You have to drain the pericardial fluid. So that's a procedure. You have to get the culture and sensitivity, find out what type of the organism is it, and give antibiotics accordingly. And in also pericarditis second or pericardial effusion secondary to malignancy also needs drainage because it can accumulate slowly and can cause tamponade. And also in uremia, of course, in uremia, dialysis is the associate treatment you have to give. Only by dialysing, uremia decreases, the blood urea decreases, and also the pericarditis will decrease. So in patients with chronic renal failure or acute renal failure, after dialysis, the pericardial friction rub will decrease or will be absent because of the resolution of the pericarditis. So the sequelae or complications of acute pericarditis is commonly the cardiac tamponade, which could be acute or subacute, and constrictive pericarditis. Now, pericardial effusion. So pericardial effusion can occur from any acute pericarditis. And commonly we see hypothyroidism. In hypothyroidism, it's due to increased capillary permeability. Then congestive cardiac failure, due to increased hydrostatic pressure, there will be associated pericardial effusion. In cirrhosis, chronic liver disease, cirrhosis, due to decreased plasma oncotic pressure, due to hyperproteinemia, there can be effusion, pericardial effusion associated can occur. Then in lymphatic obstructions, chylous effusion can occur. Then in aortic dissection, it can cause a hemorrhagic effusion. So the pathophysiology of effusion is that the pericardium is stiff. When there is pericardial effusion, the pericardium is stiff, so the motility or the motion of the heart is restricted. So when it goes above a critical volume, when there is a rapid increase in pressure, it will lead to a cardiac tamponade. So the factors that determine the compression of the heart is the volume and rate of accumulation of the volume of the pericardial fluid and the rate of accumulation, whether it is rapid or slow, and also the pericardial compliance, whether the pericardium is able to stretch. Okay. So clinical features include, sometimes the patients will be asymptomatic. If asymptomatic, there will be chest pain, dyspnea. Patient will be having dysphagia because the pericardium posteriorly, the accumulation of pericardial fluid can cause compression of the esophagus and can cause dysphagia. It can cause hoarseness of voice due to compression of the recurrent laryngeal nerve, especially the left side. Then can cause hiccups because the phrenic nerve goes through the along the side of the pericardium. So due to the irritation of the phrenic nerve, it can cause hiccups sometimes. And then if there is rapid increase in the pressure in the pericardial sac, then can lead to tamponade. So you can get features of tamponade, which I will be mentioning later. On examination, there will be muffled heart sounds because of the pericardial fluid surrounding. On auscultation, the first and second heart sounds will be not heard, loud, usually. Then there is absence of pericardial rub. Because of the effusion, there is no rubbing of the visceral and parietal pericardium, so you will not hear a pericardial rub. Then important sign is Ewart sign. In Ewart sign means if you at the inferior angle of scapula on the left side, if you look for the vocal phrenitis and all, it will be decreased. And also the you will get a egophony over there. Egophony means if you ask the patient to say E, you will hear it as A. So that is egophony. That is because of associated atelectasis of the lung, because of the compression of the heart over the nearby segment of the lung. There is atelectasis. So over that part, if that is on the inferior angle of scapula, if you auscultate, if you ask the patient to say E, you will hear it as A. So that is Ewart sign. Now diagnostic studies. In chest X-ray, if you take a chest X-ray, if there is more than 250 ml fluid, you will get a globular cardiomegaly. And in ECG, the ECG will be low voltage, and there will be electrical alternates. So this is low voltage ECG. Low voltage ECG means if you if you look at the lead one, the QRS height is, so you know, one square division is corresponds to 1 millivolt. So if you look at here, the QRS height is less than one large division. And also in this is the limb leads. In chest leads such as V1 or V2 and etc., the QRS amplitude is less than 2 divisions, 2 large divisions. So that is low voltage ECG. Normally it should be more than that. And also the another feature is electrical alternates. So if you see here, I have drawn arrows. See, if you see that alternating QRS complexes, the height is different, the amplitude is different. So that is called electrical alternates, because during the because of the motion of the heart, this occurs because of the motion of the heart and the fluid-filled pericardial sac. So there is variation in the voltage recorded. And also in echocardiogram is the most helpful study. It can identify hemodynamic compromise also. So if you see the X-ray, you can see the globular distension of the heart. So if you compare a normal heart and the large pericardial effusion, mostly you can see that it is a stencil shaped borders. That means you can clearly see the borders of the heart as if you have drawn with a stencil. So that is classic of pericardial effusion. And also the base of the heart looks like, the base of the heart means the upper part. That's not enlarged. In cardiac failure and all, you can also see the base of the heart maybe somewhat, there will be mediastinal widening. But here there is not, it's not enlarged, only the lower part of the cardiac silhouette is enlarged. For treatment, if the cause is known, that is the etiology is known, treat accordingly. And if it is unknown, we have in order to find the cause, you have to do a pericardiocentesis or a pericardial window. Pericardiocentesis has to be done, and you have to do a pericardial fluid analysis. Now, if it is a cardiac tamponade, it is the emergency treatment is a pericardiocentesis or a pericardial fluid drainage or putting a pericardial window. Now, cardiac tamponade. Cardiac tamponade is accumulation of the pericardial fluid under pressure. All cardiac chambers are compressed due to increased intrapericardial pressure to the point of compromising venous return to the right atrium. As a result, progressively the cardiac output decreases, and so that can lead to death eventually. So what are the symptoms? Again, cardiac tamponade, there is acute increase in pressure, so it will produce chest pain. Patient will be having shoulder discomfort due to irritation of the phrenic nerve and diaphragm and all. There will be abdominal discomfort. Patient will be having nausea. And on examination, patient will be having tachycardia, elevated JVP, hypertension will be there. Patient will be having low BP, sinus tachycardia, elevated jugular venous pressure. Then patient will be having pulses, paradoxes, and sometimes you can hear a pericardial friction rub also. So acute versus subacute. So tamponade can be acute and subacute. In acute, there is a sudden increase in the pericardial fluid. This is a rapid rise of pericardial fluid from normal 50 ml to 200 ml. And usually in acute TAMRNATE, usually the amount of fluid will be 200 to 300 ml. There is a sharp rise in pressure, and usual causes of acute TAMRNATE are traumatic rupture of the ventricle, as in iatrogenic, due to iatrogenic cause, or a blunt trauma, or secondary to aortic dissection, or in myocardial infarction due to necrosis. There could be a ventricular wall necrosis, myocardial necrosis. There could be a ventricular wall rupture and a hemopericardium, accumulation of blood in the pericardium that can cause acute TAMRNATE. In subacute TAMRNATE, it's a slow process. The pericardium, as it is a slow process, there is time for the pericardium to stretch maximum. So the amount of the pericardial fluid accumulating can go up to 2 liters. And there is only a minimal increase in pressure. So it's a slow process. And usually the etiologies causing a subacute TAMRNATE are infections, malignancy, post-myocardial infarction, then post-procedures can cause. Not during procedure, post-procedure. During procedure, there is a traumatic rupture. Then uremia can cause, and collagen vascular diseases also can cause a subacute TAMRNATE. And any cause of effusion may lead to what happens in TAMRNATE. There is the diastolic pressures elevate, and the diastolic pressures inside the cardiac chambers elevate, and it becomes equal to the pericardial pressure. So there is impaired, the left ventricle and the right ventricle cannot expand and fill. So there is impaired RV and LV filling, and there is increased systemic venous pressure. So systemic venous pressure increases, and there is a decreased cardiac output, as well as stroke volume, as well as cardiac output, and patient goes into hypotension and shock. And especially in subacute variety, the patient will be having a right-sided heart failure with edema and fatigue, in the subacute variety. In acute, you will classically find the Beck's triad, that is distended neck veins or elevated JVP, hypotension, patient goes into shock, and muffled heart sounds. The heart sounds will be muffled. So this is Beck's triad, which is classically found in acute cardiac TAMRNATE, can also be found in subacute. And patient will be having sinus tachycardia because patient goes into shock. And the feature is, classical feature is pulsus paradoxus. What is that? You know that normally during inspiration, due to negative intrathoracic pressure, there is a drop in our systolic BP, but it is usually less than 10 millimeters of mercury. So it does not have any hemodynamic significance. Whereas in case of cardiac TAMRNATE, there is pulsus paradoxus. This decrease in the BP during inspiration, normal inspiration, is more than 10 millimeters of mercury. So you know how to check for a pulsus paradox. You have to check the BP of the patient as normal. You have to tie the BP cuff and inflate the cuff to the systolic BP. That is to a point where the Korotkov sounds start hearing. And if you and slowly deflate. So you can, if you observe that, you can observe that during inspiration, the Korotkov sounds will, at a particular BP, during inspiration, the Korotkov sounds will disappear, but it will appear during the expiration. That is, there is a fall in the systolic BP during inspiration. And that difference, that is when the Korotkov sounds are heard during expiration, and the point where the pressure where the Korotkov sounds are heard all over during the inspiration and expiration. That difference in BP is, if it is more than 10 millimeters of mercury, then you can say it is pulsus paradoxus. When that difference becomes even more than 20 millimeters of mercury, you can, if you check the pulse also, you can feel that the pulse suddenly disappears during inspiration. So that is the, that's why it's called pulsus paradoxus. Okay. So what is the physiology between in pulsus paradoxus? Normally the septum during inspiration, due to negative intrathoracic pressure, normally the intraventricular septum moves towards the left ventricle with inspiration due to increased venous return, and there is a decrease in the left ventricular filling normally. With the compression by the pericardial fluid and also a fixed volume, there is even greater limitation of the left ventricular filling, and a reduced stroke volume. So pulsus paradox is also seen in other conditions such as COPD and acute severe asthma. So in echocardiography, there is compression of the right ventricle and right atrium in the diastole. So if you see the picture, it's a GIF. That is an echocardiographic view of all four chambers of the heart. So you can see the diastolic RV collapse. The chamber just below the right ventricle is the left ventricle. Okay, and also if you carefully see that, you can see that the intraventricular septum is bulging in towards the left ventricle. So that it can have, and you can see the above the right ventricle, you can see a hypoechoic area. Hypoechoic area means a black area, that is the effusion. So it can have localized effusion with localized compression of one chamber. So you can see either localized effusion, especially post cardiac surgery, localized effusion can be seen. And also while doing an echo, most probably we will be seeing the patient in shock. So we have to rule out other causes of shock other than tamponade. So echocardiography will help us to differentiate other causes of low cardiac output. Then definitive diagnosis is via cardiac catheterization. We can measure the intrapericardial pressures and also the pressures in the various cardiac chambers. So that is the definitive investigation. So this is the tracing of the jugular venous pressure, the waves, you know, the waves. So in normally, you know that normally you have the A wave, positive waves, A and also a C wave, then B wave. And there is a two descents, negative waves, X descent and Y descent. In tamponade, this X descent will be exaggerated and Y will be absent. See, there is no Y wave. Whereas in constrictive pericarditis, the Y will be exaggerated as well as the X will be exaggerated. So the exaggerated Y wave is classically present in constrictive pericarditis, whereas it is absent in tamponade. So this is another figure showing the echocardiographic findings. This is a pressure volume curve of the after cardiac catheterization in tamponade. So the treatment in tamponade, as I have earlier mentioned, it is immediate pericardiocentesis. So this is a method of doing a pericardiocentesis. We aspirate or we use a syringe, and the site of pericardiocentesis is the parasyphoid area, and the direction is towards the left shoulder or left axilla. And we introduce a catheter, a pigtail catheter into the pericardial cavity after we reach, and then we drain the fluid. And we use the fluid for various, we analyze the fluid for various investigations. So what all things we look for in pericardial fluid? The pericardial fluid is stained, gram staining is done to rule out any gram positive or gram negative bacterial infections. Culture and sensitivity is done, and also it can be stained for AFB, pericardial stain, or it can be sent for CB-NAT to rule out a tuberculous effusion. Then cytologic examination to rule out malignant cells. Then cell count is looked to rule out hemorrhagic or even a purulent effusion. Then protein levels are looked for to differentiate between exudate and transudate. So the pericardial protein by serum protein will be 0.5 in more than 0.5 in exudate, and also the LDH level in the pericardial fluid as well as the serum fluid will be taken and compared, and the ratio will be more than 0.6 if it's an exudate. Then the adenosine deaminase level or the ADA level will be elevated more than 30, and it is sensitive and specific for TB. So if you find ADA level is elevated, you can, or if you find the CB-NAT for TB in pericardial fluid is positive, detects Mycobacterium tuberculosis, you can start on ATT. Now next is constrictive pericarditis. Most common etiology of constrictive pericarditis is idiopathic, or sometimes it could be viral, because unless we do viral PCR and all, we will not find the cause in most of the viral infections. So most of the causes will go under, or most of the cases will go under idiopathic. Now, any cause of pericarditis can also cause constrictive pericarditis. Most probably recurrent pericarditis can lead to a constrictive pericarditis. And post-cardiac surgery, and another important cause is tuberculosis can cause a constrictive pericarditis. So the pathology behind constrictive pericarditis is that due to there is organization of the pericardial fluid. It becomes more solid, there is scarring, and also the fusion of the visceral and parietal layers, and eventually there is calcification. So because of that, the pericardium becomes stiff, there is impaired diastolic filling of the chambers, elevated systemic venous pressures, reduced cardiac output, and there is a dip in the Plateau curve on cardiac catheterization. So this is called as a square root sign. There is early diastolic filling wave, there is a dip. So this is called a square root sign, like a square root in our mathematical symbol for square root. Now in constrictive pericarditis, the symptoms are, because there is decreased cardiac output, patient will be having fatigue, also hypotension and tachycardia. There will be jugular venous distension, and due to systemic venous congestion, there will be congestion of the inferior vena cava and portal system, and then that will cause hepatomegaly and ascites, and patient will be having edema. So when such patients present with hepatomegaly, ascites, and edema, and also it can confuse with cirrhosis. So if a patient is having elevated JVP, most probably it will be a cardiac cause. So you have to rule out whether it is purely a hepatic cause or it is secondary to a cardiac cause. And also in constrictive pericarditis, ascites appears earlier, whereas in chronic liver disease, ascites appears in a later stage. So you have to ask for the progression of the disease. Then on examination, there will be a pericardial knock. It is a diastolic low-pitched sound which is heard after the second heart sound, S2, due to sudden cessation of the diastolic filling, ventricular diastolic filling. Why? Because the expansion of the left ventricle or the right ventricle is restricted due to the stiff pericardium. So when there is a sudden cessation, there is a characteristic sound is heard, which is called the pericardial knock. Next is the Kussmaul sign. Kussmaul sign is there is jugular venous distension with inspiration. In contrary with the other sign which we studied, pulsus paradoxus, there is jugular venous distension with the inspiration. Okay. Then there is no pulsus paradoxus. Pulsus paradoxus is found in cardiac tamponade and COPD and acute severe asthma. And clinically, it is difficult to separate constrictive pericarditis from restrictive cardiomyopathy. Even with echocardiogram, it is difficult to differentiate whether it is restrictive cardiomyopathy or it is constrictive pericarditis. So in that case, they may need a myocardial biopsy. So these are the various features that distinguish cardiac tamponade from constrictive pericarditis, a restrictive cardiomyopathy, a right ventricular MI, and an effusive constrictive pericarditis. That is constrictive pericarditis with effusion. So this is a table from the Harrison. So this table shows various clinical features of around 5 conditions. So in tamponade, you know that clinically the pulsus paradoxus will be present in tamponade as well as effusive constrictive pericarditis, whereas pulsus paradoxus may not be present or even absent, may be present rarely in other 3 conditions. And if you check the JVP, there will be a prominent X descent in tamponade as well as restrictive cardiomyopathy as well as effusive constrictive pericarditis, but it is not prominent X descent in constrictive pericarditis. Then prominent Y descent is present in constrictive pericarditis. Other conditions, it's not prominent, it's absent in tamponade. Y is absent in tamponade as well as effusive constrictive pericarditis. And Kussmaul's sign is positive in constrictive pericarditis as well as right ventricular myocardial infarction. Then third heart sound may be present in right ventricular myocardial infarction as well as restrictive cardiomyopathy. Pericardial knock is classically present in constrictive pericarditis only. And if you look at the ECG, electrical alternance and low ECG is classically seen in tamponade. It may be also be present in effusive constrictive pericarditis. Low voltage VCG may also be found in constrictive pericarditis and restrictive cardiomyopathy. And in RVMI, you will find the typical features of right ventricular myocardial infarction in ECG, typical ST T changes. In echocardiogram, also in tamponade, you will not find any thickened pericardium. There will not be any pericardial calcification. Pericardial effusion will be there, and the RV size will be usually small, and there is exaggerated respiratory variation in the flow velocity. That is, there is pulsus paradoxus. The physiology of pulsus paradoxus. Then in constrictive pericarditis, thickened pericardium is present and pericardial calcification is present, and the right ventricular size will be normal. In restrictive cardiomyopathy also, there is no thickened pericardium or pericardial calcification. In echo will be normal. In right ventricular MI, the RV size, there will be RV failure. So there will be right ventricular dilatation. And effusive pericarditis also there will be, because it has got effusive constrictive pericarditis, it has also got features of constrictive pericarditis. So there is thickened pericardium as well as pericardial effusion. So the definitive, in case of constrictive pericarditis, echo is not a definitive investigation. You can't tell it is constrictive pericarditis. There should be evidence of thickened pericardium. It cannot be, you cannot definitely say that there is the thickened pericardium in echocardia. So for that, we need a CT, either a CT chest or an MRI of the heart to demonstrate a thickened pericardium. Okay. So in order to differentiate between restrictive cardiomyopathy as well as constrictive cardiomyopathy, you have to take a CT or MRI. So this is an X-ray of a constrictive cardiomyopathy. You can see the calcification. You can see the white rim-like structures. That's the calcification of the pericardium. And you can see that there is no cardiomegaly. The heart size is normal, because this heart is normal size, because there is no dilatation due to the stiff pericardium. Now this is the CT image of a constrictive pericarditis, where you can see the thickened pericardium. And also the patient is having a left pleural effusion. So treatment of constrictive pericarditis is definitely pericardial resection. And also the treatment of underlying etiology if present, if active, for example, TB or collagen vascular diseases. So the part for the treatment part for the constriction that causes a hemodynamic compromise, pericardial resection is a treatment, and other treatment of the other etiologies, the etiology. So that's all about pericardial diseases. Any questions? Do you have any questions?
No, ma'am.
Okay, if not, shall we end this presentation?
Okay, ma'am. Thank you, ma'am.
Okay, I will send you the presentation slides to your WhatsApp, so you can share with your friends. Okay.
Okay, ma'am.
Okay, thank you.